I'm Philip Poortmans, radiation oncologist, trained in Belgium, spending a lot of years in the Netherlands, a couple of years in France, and now I'm back as radiation oncologist in the Iridium network nearby Antwerp in Belgium. I had the pleasure and the honor to give 2 presentations at the recent BGICC in Cairo, which unfortunately need to be held virtual for the reasons I don't need to remind anybody. This presentation was about re-irradiation in breast cancer. Now, re-irradiation is quite a challenge for radiation oncologists, and it depends a lot on where you were trained. In the past, it was very simple. You cannot re-irradiate. A lot of data challenged this, and some of the very challenging data came from Bert van der Kogel, a famous radiobiologist, who did re-irradiation in the 70s and the 80s, among others with a special type of monkeys, the rhesus monkeys, which are quite similar to human beings. And they found very encouraging results that there is repair of sublethal damage, which means that if you wait long enough, you can re-irradiate. But it depends on a number of factors. Because in some countries, it's used a lot. In other countries, it's used not at all, re-irradiation. Clinical Oncology, the journal, published a dedicated issue in 2018 on re-irradiation. It started with the principles and practice from the late Wolfgang Dörr and Dorothea Gabriz, and I highly recommend you to read that as a starting base. Furthermore, in this journal were a number of chapters, and I had the pleasure to contribute to the chapter on breast cancer re-irradiation and hyperthermia. So the basic principles are that we cannot have advices that are valid for everybody. It is a decision that needs to consider a lot of components. First of all, where is the to be re-irradiated target volume relative to the initially irradiated target volume? What are the parameters of the initial radiation therapy? The dose, the fractionation, and the volume. Don't underestimate the volume, the size of the volume. What were other treatments given? Chemotherapy, biologicals? And what is the time interval between the earlier irradiation and now? And how does the patient look like? How is the quality of the irradiated tissue? In the case of the breast, how does the breast feel? Is there a lot of fibrosis? How is the quality of the skin? And of course, for each patient, you have to discuss what are the possible advantages of re-irradiation and what are the possible drawbacks. And for this, of course, quality of life is of paramount importance as well. So the basic principle is individualize. Speak with your patient and perform a good clinical examination. Then look at the data of the early radiation therapy and the current situation. And then start thinking and discussing. A nice example is a patient who had 20 years ago low dose radiation, 30 gray, to the neck or the axilla for a Hodgkin lymphoma. And now she has a breast cancer. This will rarely, if ever, pose any problems for a proper re-irradiation of the breast and even the regional lymphatics. The other extreme is a patient who has been treated with full dose local regional radiation therapy for breast cancer 2 years before, and now has local and regional recurrences. There we are strictly limited by what has been given. But depending on how the quality of the skin and the subcutaneous tissue is, we might reconsider nevertheless to give re-irradiation. But that are the 2 extremes. Most of the patients come with you with something in between. For example, breast conserving therapy 10 years ago, a recurrence, and the mastectomy was showing very bad signs, and she needs post-mastectomy radiation therapy. What can you do? So often it comes to, is the glass half full or is the glass half empty? But in any case, again, speak with the patient, examine the patient, and look at all the parameters. Most of the patients who had breast cancer before and are possibly eligible for re-irradiation have a chest wall recurrence. We have shown over the years that the risk or the frequency of breast cancer recurrences decreased a lot from the 80s till now. From without radiation therapy, easily 20%, 10 to 20% in the 80s, and with radiation therapy still, let's say, around 5%. Now we go to 5 to 10% without radiation therapy, 1 to 3% with radiation therapy, depending on the risk factors, of course. So we see less chest wall recurrences, but we still see them. So in those patients, we have to consider time interval, quality of the skin, and often consider re-irradiation. One of the very potent radiosensitizers that has been extensively described to be combined with re-irradiation of the chest wall is hyperthermia. In my presentation, I gave a number of examples, also showing specifications of hyperthermia. What does it need to be? When should the hyperthermia in the radiation therapy in time be spaced one to another? Hyperthermia and radiation therapy can contribute to an increased level of definitive local tumor control if it is given in close margins, even if it is given in positive margins and macroscopic but limited disease. And if we have patients with bulky disease on the chest wall, it is a very valid tool to give a very good palliative result, which is long-lasting, but only in a minority of them forever. Other sites of recurrences are, for example, the lymph nodes. Now, for the lymph nodes, many of those patients had earlier breast treatment, but without lymph node irradiation. So for those patients, we can give elective nodal irradiation with a boost to the recurrent lymph nodes if required. Some patients had regional nodal irradiation before, and then we have to look to the vicinity of the risk organs. And the risk organs are especially at the level of the spinal cord when very medially located in the level 4 of the axilla, also known as supraclavicular, and the brachial plexus. We can use the calculations and the publications from Bert van der Kogel to estimate recovery over time of neural tissue, but it remains a balance between obtaining local control and risking late toxicity at the level of, for example, the spinal cord or the brachial plexus. Reassuring is that if you use the ESTRO guidelines for elective nodal irradiation, that nearly no nodal recurrences occur outside of them. So they're properly defined for elective nodal irradiation. And then another growing field is second breast conserving therapy. So what we saw in the past was that breast conserving therapy recurrence always led to a mastectomy. Nowadays, more and more patients are offered a second breast conserving therapy, and most of the experience is obtained by performing a lumpectomy and subsequently partial breast irradiation with brachytherapy. However, other studies are ongoing, also using external beam radiation therapy, partial breast irradiation for a recurrence after breast conserving therapy and performing a second breast conserving therapy. The results of the brachytherapy show that it's quite efficient. After 10 years, only 7.2% second recurrences, and not that toxic. Majority of the patients have toxicity, but it is grade 1 or 2 in 90% of them. Only 10% of the patients in a big series of JAK-estro had grade 3, and only 1% of the patients had a grade 4 toxicity. So it is an option to offer second breast conserving therapy to the patients, but look when selecting them at the same risk factors as we use for selecting patients for primary breast conserving therapy, and the radiation dose, for example, boost yes, no, or partial breast yes, no. In general, patients who are eligible for partial breast irradiation are the same who are eligible for a second breast conserving therapy. So taking all this together, we have a lot of knowledge on re-irradiation, which is not yet optimally used. Hyperthermia for chest wall irradiation, which is the most frequent bothersome recurrence, is not uniformly available and should be used in more countries than is currently the case. Second breast conserving therapy is an upcoming era, and a lot of teams are investing in this, but we need to build more evidence around it to properly use it also outside of the frame of registries and trials. For all of this, patient selection should be fine-tuned, and this is valid for, of course, whatever aspect of the field of oncology. Thank you very much.